Good morning, Tri-Cities. This is Karl Dye from TRIDEC, and we are going to do Coffee with Karl right now. This morning, we're excited to welcome our guest, Niket Thakkar. I'm sorry, I actually wrote down a phonetic spelling and I just blew it, but
Niket Thakkar, yeah.
Thank you very much.
So, for having me, guys.
No, Niket is from the Institute for Disease Modeling in Seattle, I'm guessing. And today he's going to share some information with us. The Institute for Disease Modeling, I'll very generally say, works on predictive modeling for epidemics and diseases globally. And just a little backstory, last Saturday we were able to be on a call with the governor and Department of Health and local elected officials from Franklin and Benton and Yakima County. And Niket was one of the presenters from IDM on that and presented this this predictive model and talked about some of the data behind COVID outbreaks and what's going on and some of the factors that lead into even what phase we're at and other counties are at. And so we invited Niket to come on this morning, and he was nice enough to join us. And I think we'll have a really good discussion. So thanks in advance for joining us, Niket.
Yeah, I'm looking forward to the conversation.
That's right. And I think we warned you, but this is Coffee with Karl, so we kick it off and talk about like our mug or the coffee that we're drinking. So I don't know if the lights are right or not, but this is like an old school, it basically says tridec.org, and if you can tell, it's kind of some 90s font and colors. Yeah, it's the old school. So evidently the history is when we first got a website, sometime in the 90s, we had these mugs to remind everybody like, hey, we got a website. So we pulled that one out of the archives. That's my mug this morning. TRIDEC is founded in 1963. And so we've always been, I would say, an economic development agency that's focused on economic growth and job creation in the Tri-Cities. And obviously, you know, the history of the Tri-Cities relates to going back to the Manhattan Project in World War II and plutonium production. And then in the 80s and 90s, as that plutonium production was scaled back, then we moved into cleanup of the Hanford site. But we've always been the home of Pacific Northwest National Lab that you're probably, you know, pretty familiar with, being a scientist yourself and that connection. But, you know, really our focus is economic growth. And I think we talked about it a little bit before the show, but we've tried to pivot and focus as quickly as possible to say during COVID, what are we doing to try to help business, to try to help recovery, to try to help, you know, how do we come out of this? And hosted this weekly Zoom series as part of that to bring, you know, data and folks to the table that we can have a good discussion and, you know, kind of get a little bit more in depth on some of these discussions and help have some better outcomes. So that's kind of our backstory and my coffee story. So what do you got this morning, Niket?
Thank you for telling me. I didn't actually know that history of Tri-Cities, though I went to UW, and so PNNL had a big presence at UW. So definitely I've heard of all that. So I have my mug. I have my NASA mug, which like has some connection to my research roots. My like first ever research project when I was like a freshman in college, I went to the University of Arizona. I grew up in Arizona.
Yeah.
And so I was in Tucson, and I got involved in this program called NASA Space Grant, which I actually don't even know is still a thing. It might not be, but at the time it was a way for undergrads to get research funding and to start research projects. And I worked on solar energy at the time, and I was a physics undergrad. And you know, I was a freshman in undergrad, so I didn't really know anything, I feel like. and so like I was thinking about this in preparation for this story, and my memories of that research project are really just like burning myself with a soldering iron like over and over again as I'm trying to like make solar panels together. And just like we worked a little bit with Tucson Electric Power, and so I helped set up their solar grid at the time. And part of that solar grid was like an experimental solar grid that we were taking measurements on. And I think like one of the things that was just like really impactful about that particular experience, and the reason I like my NASA mug despite the soldering burns, is like, you know, I didn't really know that much, but it was really confidence building for me that, you know, maybe I had a place in research and maybe I had a career here. And I think it was, the beginning of a long trek all the way to here.
That's awesome. And I did want to say one more thing. I saw in your bio that it was talking about some of the things you like to do. And there was a reference that you're always looking for really good Mexican restaurants. And so as we come out of the COVID, as we go to phase 2, phase 3, phase 4, we want to invite you to the Tri-Cities. We have very, very excellent Mexican food and really, really good restaurants and even food trucks that are here. So open
Excellent.
Invitation.
Yeah,
you will be our guest when you come to the Tri-Cities, and we'll go have some good Mexican food.
I'm very excited. Yeah, I will be there.
That's awesome. Well, do you want to go ahead and share your screen, and we'll get right into your presentation, and then we'll open it up for questions and have a good discussion.
Can you guys see that?
Yes.
Excellent. Yeah, so I thought maybe I would begin by just introducing IDM a little bit. IDM is a research organization that's an independent research organization in Seattle, and we originally started working on global health problems. So in particular, working the original projects were associated with malaria prevention. Over like a 10-year period or so, IDM grew into a bigger organization. It's about like 100 researchers and software engineers. And we produce open source software, and we produce research to try to support long-term changes in people's health around the world. So for example, for me in particular, before COVID became a thing in December, I was working on measles projects. And in particular, I was supporting measles vaccination efforts in places that are really disproportionately affected by measles around the world, like Pakistan or Nigeria or Ethiopia. And there's, a limited supply of vaccine, and getting vaccine to the right places at the right times requires us to look at where we think measles is, and other things about the demography, how many kids are being born, and to what extent are those kids being vaccinated when they're young. That gives us a sense of how big do we expect problems to be in the future associated with measles, and to what extent can we prevent those problems with targeted vaccination efforts. So that's been largely my focus as I've been at IDM for the last little while, trying to support those kinds of vaccination efforts. But then in January of this year or so, as COVID became clearly a more present problem in our own communities in Washington, in Seattle, and King County, and elsewhere, a handful of us at the Institute started working more closely on COVID-related projects. And so since then, we've started to build a pretty good relationship initially with Public Health Seattle King County, which was our neighborhood public health department, but over time, more broadly, trying to support COVID prevention and mitigation efforts across the state as much as possible. And I think the way I sort of conceptualize our role these days is very much so trying to understand the data as best we can, and providing our independent volunteer opinion on what we think is going on to elected officials and to public health officials. So I thought I would get us started with something that maybe some people have seen before, but also just kind of a general sense of what models can do for us and why we use them. So models give us insight into processes we can't measure directly. So when we talk about measuring COVID, what do we get to see? We get to see COVID cases. We get to see people going to the hospital. We get to see a COVID-related mortality. And all of these give us some incomplete picture of what's actually happening, which we know is person-to-person COVID transmission that we don't get to see. And so a model is a way that we can think about that transmission process and how it gives rise to the types of things we observe. And so one piece of that transmission process is something we call the effective reproductive number, which is something that we've been showing to the governor's office and to other health officials in Washington as a way to conceptualize the current picture of transmission in different parts of the state. So the plot I have here is one of our latest versions of that, using data that was compiled on Saturday or Sunday, June 14th. And in purple, like husky purple, there is Western Washington, and then in cougar red there is Eastern Washington. And what this is a measure of is, on a given day, how many people on average did an infected person pass their infection on to? And so, early on in the epidemic, in early March, before mitigation efforts were really widespread, before people were wearing masks and things like this, there was this steep fall across the state in how many people were getting COVID from infected individuals. So early on, a person on average would pass their infection on to 3 people, which is a rapidly growing problem because those 3 people pass it on to 3 more people, those 3 people pass it on to 3 more people, and suddenly we have an exponentially growing process. Over time, throughout the month of March, leading up to the stay home, stay healthy order on March 23rd, we saw this steep decline across both states, both sides of the state. And I think like the critical difference though between the red curve and the purple curve is this threshold of R effective is equal to 1, and that the purple curve is below it and the red curve is above it. So what do we mean by that? R effective equal to 1 tells us whether or not our epidemic is growing or shrinking. If R effective is just above 1, then an infected individual passes their infection on to a little bit more than 1 person on average. And so every day we get slow growth in our epidemic. That's what we think is happening in Eastern Washington, and that growth is getting faster over time since that initial fall after March. Meanwhile, in Western Washington, there have been these periods of sustained shrinking. So periods of time where a person passes their infection on average to less than 1 person. And that's led to some of the declines in cases and things that we've seen in Western Washington. And so this is something, the type of thing that we're showing to people like the governor's office as a way to give one perspective on the data that we're seeing. And it's one perspective that we think is valuable because it's connected to something we have control over, which is our person-to-person transmission as we move about and do the things that we do every day in our lives. So this is kind of the high-level discussion of how we're using models at the state level. But like I said, we've been focused recently on Benton and Franklin counties in the Tri-Cities area. And so the rest of what I have prepared is very specific to our efforts at understanding the epidemiology in Tri-Cities. So this is the data that we get. And I wanted to show you guys just to give you a sense of what I see when I look at this data. So the top panel of this data, the x-axis there is time. So it starts in March 1st, and it goes all the way till June 14th. And the top panel over there is positive COVID-19 tests. The middle panel is total tests, so positives and negatives. And you get a sense of testing volume over time. And then the final panel there is COVID-related mortality in Benton and Franklin counties. And so one of the most prominent features you can see is this big spike in late April, I think like April 22nd or 23rd, which is associated with the Tyson fresh meatpacking plant in Wallula. And so that was a situation where we had this large spike in positives that the health system was able to catch. Then shortly after that, what we see in the data is this increase in cases over time, slowly but steadily increasing numbers of cases, positives in the top panel. And then we can look at the middle panel and say like, okay, total tests are not increasing really at the same rate. They're roughly constant over that same period. And so already just from looking at this data, no models or anything, we can see like, seems like we have a growing problem that warrants attention in Benton and Franklin counties. And then the other thing I wanted to pay attention to is the colored lines. So we get data through the Washington DOH, what we call the WDRS, the Washington Disease Reporting System, which is a compilation of all the testing data and mortality data in the state. And our colleagues provide this to us roughly weekly. And so what I have is every Sunday's version of that data for the last few weeks. So the latest that we have is the black line, and that's what I'm going to be using sort of throughout to do modeling and things like that. But what I think you can see is that information is lagged, right? So the orange lines and the blue lines are retrospectively different than the black line. And in particular, all of the lines have this fall at the very end, but that fall has more to do with the time it takes for testing data to become a part of the testing data system than it does for anything to do with epidemiology. And so these types of features of the data that There are lags associated with how fast we can get tests completed. It takes time to do a PCR test, things like that. Those types of features of the data are things we have to account for when we try to understand the transmission process. Does that make sense?
It does. And I had a question on the first chart, which I think is overall cases, but each kind of data point on the chart are new cases, right? Like it's not a cumulative aggregation. It's just these are the new reported cases per day or per week.
That's right. That's a really good question. These are new reported cases, and they're being plotted by specimen collection date. So not the date that they were reported to the system, but the date that the swab was actually taken.
Okay. So again, when you talk about the factor of time, that's actually when they were tested with the swab, not when we knew it was a positive test. And I think that's why I wanted to ask that question on the first one, because what you're talking about is the trend line is going up per day. We are seeing more new specific cases. It's not just a aggregation. It's like, these are new cases and this trend line's going the wrong way.
Exactly right. Exactly right. And the reason as an epidemiologist that we care about the specimen collection date is because that's the date that this person was infectious in the population. So for you to have a PCR positive, it means you're also spreading the disease to others. And that's really what we're interested in. We're interested in this transmission process and how fast, what rate is the disease spreading through the community. And then the last thing I think I'll point out on this, just in terms of the overall data, is that, thankfully, mortality is on average 1% of the deaths. So that's 20 times the level for flu. It's still a very lethal disease. But it's numbers that are like in this plot 4 deaths a day at most at this moment. Now, as a result, it's very hard to look at the mortality data and see any definitive trends, right? It's hard to say, is it going up, is it going down, because we're talking about very small numbers, at least at the moment. Now, one of the things a model allows us to do is to see, do we think that that's actually a trend going up, or do we think that that's something else? And so I'll come back to that, I think, as we start to build the model. Okay, so we can do the same sort of thing that we're doing for Eastern Washington and Western Washington in using a model to understand the effective reproductive numbers specific to Benton and Franklin counties. And so what I have there in the top panel is the same test positivity data from before, the top panel from the previous plot. And I have in the bottom panel is specific to Benton and Franklin. What do we think the reproductive number is over time? So how fast is transmission happening in the Tri-Cities area? So kind of like Eastern Washington as a whole, early on in the epidemic, in the middle of March in this case, transmission was happening quickly. A person was passing their infection on to just under 3 people on average. And then throughout the month, the latter half of March, that number decreased really significantly, right? Our point estimates in early April are actually even below 1. And so I think what that speaks to is something that I want to emphasize, that physical distancing and non-pharmaceutical interventions have worked in the past in Benton and Franklin. So they have already averted a serious amount of COVID-19 burden and mortality. Then, as you go through sort of the time course there, you get this big bump associated with the timing of the Tyson fresh meats shutting down and all the testing associated with that. So that big bump probably is, our model gives us a way to sort of distribute that in a reasonable way associated with how fast transmission happens person to person across that time period. And I think one of the things that this sort of story gives us is that, okay, the Tyson meat plant was this big event. And then after that, there was this loss of control of transmission. So while in late April, transmission was, a person was passing their infection to less than 1 person, that slowly increased throughout the month of May. And, as we look at the data, we might have this intuition that increase had something to do with the Tyson fresh meats plant. But one of the things that's complicated is that we only get to see a subset of the actual infections. Part of that is because a lot of people who are infectious are asymptomatic and not being tested. And part of that is because of testing volume, that even people who are mildly symptomatic are not being tested. And so we're just missing a good number of the infections. So while we look at the data and say, okay, it seems like this Tyson event was a big piece of the epidemiology, one of the complicated things is that we might be missing a big piece because of our lack of testing and basically not being able to test every single person every single day. And so the model allows us to kind of reconcile that and estimate what fraction of cases we're actually catching. But overall, I think here in the latest estimates we have at the end of May there, transmission is growing and the epidemic is growing in Benton and Franklin. So our estimates are that like roughly 1.3 people are being infected by every person being infected. And so as a result, that epidemic will grow in size slowly but steadily.
That's great. And I see your note on the slide that even after like the spike in testing and cases that's associated with the Tyson Foods plant, even though the transfer rate dropped below 1 during that time period, we don't really have data that says, yeah, this is for sure a correlation, that because of the Tyson food and testing and maybe awareness or something, that the transmission rate went down. We just know that it went down, don't really know exactly why.
Yeah, that's such a key point. Models give us this description at the county level, this particular model. And it's good for that as an indicator of what do we think is going on in the data. But it doesn't give us a causal understanding of what actually caused the transmission to go up. Was it changes in behavior associated with people's awareness? Was it changes in behavior associated with the weather? Was it changes in behavior associated with all sorts of things? All we can really say for sure is that there was a change. And it led to this change in outcomes in terms of COVID-19.
You bet.
Great. So on top of, as we generate numbers like the effective reproductive number, one of the things that we do is we build a full transmission model. And what I mean by that is we build a model of the population in Benton and Franklin counties, where people in the model are either still susceptible to COVID-19, they might be exposed to COVID-19, but not yet passing the infection around, or they might be actively infected with COVID-19. And we can model the interaction between those populations based on that effective reproductive number. So this is how fast and to what extent the infectious population is interacting with the susceptible population. That lets us start to estimate things like how many cases do we think we should have observed in the model, and how many deaths do we think we should have observed based on the model. And the reason we want to do those kinds of inferences is to compare to what we actually saw. And that gives us a sense of whether or not our model is doing a good job. So what I have here is the same testing data, this time in the bottom panel, the black dots, and the same mortality data that I showed you before, this time in the top panel, also the black dots. That's what we've observed in Benton and Franklin counties. Our model is being shown in the colors. So in the top panel, the best estimate of the model is this line, which is the mean of a bunch of different situations that we can simulate from the model. Given a model that has fitted parameters, we can run these simulations and get a sense of what kinds of outcomes we observe. And those outcomes have some spread. There's some random chance associated with transmission, just bad luck when it comes to getting COVID. And so that random chance gives us this spread of outcomes that we try to characterize with this distribution. And that's what's being shown in the colors. So 50% of those trajectories fall within the darkest region. 95% of those trajectories fall within the light region, and 99% of those trajectories fall within the lightest region. And so what you can see is that in both the death data and the case data, we're catching this trend over time, right? And in the case data, we have to do things like account for weekends. So this jagged pattern is that there's less testing on the weekends because, people take breaks, and that's important. We have to live as a society still, despite this growing problem. And I think one of the things that I like to see about that jagged pattern, if I just divert for just a second here, is that each of these dots is the sum total of a ton of work by a ton of healthcare professionals, right? Doing these tests, understanding what's happening on the ground, that takes a really well-functioning healthcare system. And so, as a high-level epidemiologist working at this population-level picture, I'm very thankful to the people in Tri-Cities who are doing this kind of testing and getting a sense of what's going on the ground. That's the only way we can get these kinds of pictures of what we think is happening with transmission. But overall, you can see at the very end of the plot there that we expect cases to grow if things continue, and we expect mortality to grow in an associated way. Any questions on this?
No, I think that you just summed it up really well, that the trend line of the predictive model with the colors, as you explained on the testing, positive tests on the bottom chart, the trend line's going the wrong way, that you're predicting that we're going to continue to rise based on the accuracy of your model to date versus the actual tests. And what you're saying predictively is we're going to continue to increase based on current data.
That's right. And what this tells us is that the R effective numbers that we're estimating are consistent with what we're observing. So gotcha. The other thing that we get from doing this, like I said before, is we get insight into the transmission process happening on the ground. So cases and deaths are things that we can just observe. But what we really want to know is how many people are actually currently infected with COVID-19. Oh, actually, before I get into that, there's one more thing I wanted to add, which is that we get other data too, which is hospitalization. And that's not actually explicitly incorporated into the model. What it gives us is an alternative picture to see if it confirms what we think is happening based on cases and deaths. So what we check is what's called CLI data, COVID-like illness, which is visits to emergency departments in Benton and Franklin counties that, the person is either diagnosed with COVID or they have a fever and shortness of breath, and doctors have ruled out that it's not the flu, it's something else. And that gives us a good sense that, okay, it's probably COVID because that's the only other game in town. And so, this black line here is CLI visits to emergency departments over time. And one of the key features of it is it goes back even into 2019. And that's because people were having fevers and shortness of breath due to things not flu, even before COVID was a thing. But these days, we have a lot of confidence that COVID is the driver of this curve. And that's because social distancing has really gotten rid of a lot of other pathogens in society. And so when we look at this black curve, kind of complementary to the trend we're seeing in the model, we see that at the last part of it, starting in mid-May, it's also going up, right? So more people with COVID-like illness in Benton and Franklin counties are starting to show up at emergency departments as well. And that's an insight that's independent of testing and independent of the model. And so it gives us a little bit of confidence that the picture we're getting from the model is a good, faithful representation of what's going on. And so I just wanted to give you this example of how we try to reconcile lots of different types of data into a single picture of the epidemiology, and the model helps us do that. But overall, what we're trying to be careful about is our model actually a good model of what's going on? And these are the ways that we check.
That's great. Niket, we just had one question from Facebook. Maybe I'll just interject really quickly because it relates to what you're just talking about. So on the effective reproductive number, there was a question about what's the goal? Is it 1 or less than 1? And you want to just touch on that quickly as we go along?
Yeah, absolutely. So the goal is definitely less than 1. And the reason that's the goal is because if it's 1, then we have a problem that's sustaining in society, right? Yeah. And our goal really is to stamp out COVID as best we can. It's to win this fight, as our governor would say, for example. Yeah. And to do that, what we really need to do is shrink prevalence, the prevalence of people actively infected. And so what does that take? And I'll get to this in more detail in a little bit, but if someone has symptoms and they stay at home and they do so sort of preemptively, then there's a good chance that they don't pass their infection on to others. And that's the kind of situation we want to be in. And so when R effective is less than 1, which is our ultimate goal, it means that a lot of people are able to do that. They're able to prevent their infections from being spread to other people.
That's great. Thank you.
Yeah, of course. So the other thing that we get when we do modeling is we, as I was saying, get pictures of the transmission process that we don't get to observe directly. And in particular, we get estimates of how many people in Benton and Franklin County do we think are currently infected with COVID-19? And how many people in Benton and Franklin counties do we think have been infected in the past, total? And that alternatively gives us an estimate of how many cases are we actually catching in Benton and Franklin counties. So the top panel here is also model output, and it's what we call population prevalence of COVID-19. So it's the percent of the population that we think currently COVID is replicating in their bodies, that are actively infected with COVID-19. And what you can see is our best estimates at the very end there, most recently, as of June 5th, are like roughly 1%, right? So Benton and Franklin counties is roughly 300,000 people. So what we're talking about is 3,000 people actively infected roughly today, right? So what is that? Maybe the size of a minor league baseball game, right? Yep. So we have this size population, and right now that's where COVID is living in Benton and Franklin counties. Simultaneously, associated with that change over time in population, we have how many people are no longer just fully susceptible, how many people have been affected by COVID-19 as far as getting infected goes, getting exposed goes. Now, our estimates of that most recently are more like 4%. So, we're talking about 12,000 people who have either had COVID and had related complications, severe infections, things like that, or have had COVID and have recovered. So that's what's going on in the bottom panel. And overall, what that gives us a picture of is currently, we think we're catching eventually that people who are infected get caught by the healthcare system and tested positive. 17% of those people are roughly what we think are being caught by the healthcare system in Benton and Franklin counties. And so one of the goals of increased testing volume is to make that number larger, right? And in doing that, we get a better picture of what's going on, and we learn something about what activities are high risk and what activities are risk we can take, in terms of the current situation. But as it is, with 1 in 100 people basically currently infected with COVID-19, as our best estimate, lots of activity is pretty risky in terms of crowds of even moderate size currently in Tri-Cities. And so oh, go ahead.
Oh, I'm sorry. It just made me think of kind of a question or something to bring out, in that sometimes people talk about, well, there's not much testing, only people that are sick are getting tested. But I think this is a great slide to show, and really what part of what you guys are looking at with your model and predictive modeling is to try to estimate who's actually sick. Because like you said, we're not able to test everybody every day. There's a lag time in incubation for the disease. So maybe you've been exposed, but it takes 4 to 14 days maybe for symptoms to show up or for you to test positive on a test. And so taking all those factors in, you guys are actually saying, we think based on our model, this is how many people are sick. And so I just wanted to reinforce that point that, I think that's for me anyway, the really interesting thing and the cool thing about your model is that you're actually trying to look at the overall effect of the disease on a community. You're not just saying, well, here's what we've got based on the testing capabilities that we have, or how many people showed up to get a test, or how many people went to the emergency room, but you're trying to actually show what's the effect on the community. I think that's great.
Yeah, absolutely. And just to reiterate the point you just made about lags, I think that's a really key point, that, the latest data we have, we're getting estimates as of June 5th, right? So that's close to recently, but it's not today. And so one of the things that a model helps us do is make sense of what we've seen, but it very much is one of these situations where we're driving, looking through the rearview mirror. And the best we can do is look through the rearview mirror and try to make really educated guesses, compiling as much information as we can about what's ahead of us. That's what a model lets us do. That we know that prevalence can't change super fast because people's infections last a few weeks. And so This is a good estimate of prevalence today, but it doesn't tell us what prevalence has to be in the future. And I'll get to that in just a bit, that one of the things a model gives us is it gives us the ability to look ahead, and in particular, say something about how differences and changes in behavior might manifest in terms of the things we observe, like cases and mortality. But zooming out for just a second, one of the things to put that prevalence number that I just told you, 1%, in context, we apply this exact same modeling approach to lots of different communities in the state. And so what I have here is 3 of those examples. So the top one is Yakima County, the middle one is King County in yellow, and the bottom one is the same Benton and Franklin County curve that I showed you previously, this time in here. And so we see it over time, and I guess one of the things that I think this really highlights is that the differences in these communities mean that COVID-19 is a different challenge. And different approaches are more or less effective depending on society and how much we're able to adapt to those approaches. So in King County, we kind of look at the data and we see that based on a model of King County, that prevalence was at its peak in late March. And that peak was roughly 1%, right? Simultaneously, in both Yakima and in Benton and Franklin counties, we think that those are at the roughly 1% peak today, as close today as we can get. And so one of the things that I wanted to emphasize is in late March, the situation in King County was very much like it was receiving really extraordinary attention. There was a ramp up in testing. There was a lot of targeted interventions. We were all trying to think about what was happening specifically in that community. And I think we're trying to get to that place right now with Benton and Franklin County. And that's why it's important for discussions like this, is to try to understand what are the specific things about the Tri-Cities community that not only we need to think about, but we can leverage to try to tackle this difficult problem. And then finally, as I was hinting at, given a model of transmission, we can ask ourselves what we think is going to happen going forward. And so what I have here is that for Yakima at the top and Benton and Franklin at the bottom, and this is the exact same slide that you saw on Saturday, Carl. And so what I've added here, the black dots are the data we had as of last Saturday. And the red dots are the data we've received since, which I know isn't very much. It's only been a week, but it tells us kind of how well do these models do at capturing trends in the short-term future. And so you can see that the red dots fall within what we would expect to happen over time. So in the colors is our expectation of the future if things stay exactly the same. And if things stay exactly the same, particularly in Benton and Franklin counties in the bottom 2 panels, we expect daily numbers of new cases and daily COVID-related mortality to grow. But then simultaneously, what we have there is in the gray, is if on Monday, June 15th, when we were talking last Saturday, there was changes in behavior that eventually reduced the effective reproductive number to less than 1 by June 22nd. In gray, what that's showing you is that these outcomes are avertible. By collective action, by each of us doing our part, we can change the course of this infection. And I think that's a key point, right? These models are kind of like weather models in the sense that we can look at a lot of information that we can observe and we can say something about what we think is going to happen going forward. But I think one of the key differences between these models and a weather model is that if you take your umbrella outside, you don't change the weather. But if you put on a mask when you go outside, you can change the outcomes of these projections. And in that way, the mask is these projections are really a reflection of our behavior as a community. And I think that's kind of a powerful idea, that the difference between this gray curve and the colored curves is things like each of our individual actions.
That's perfect. And I that's one point that we really wanted to bring out with this data discussion and the modeling discussion today, Niket, is that, there are things that we can all do. And I appreciate you making that point. I did want to remind everybody, if you're just, we're not a broadcast, but if you're tuning in, so to speak, we're having a discussion called Coffee with Karl. I'm Karl Dye from TRIDEC, and we're talking to Niket Thakkar from the Nonpartisan Institute for Disease Modeling. We're talking about data and transmission in Benton and Franklin counties. And if you have a question and you're on Zoom, you can use the question and answer feature. I think we're just about ready to get into some of those questions. And if you're on Facebook, you can post a comment and we'll try to get through as many questions as we can today. We'll know there'll be a lot of questions, but again, thank you again for this information. It's really good data, and I just kind of butted into your presentation. So let's get back to the data.
No worries at all. No worries at all. I have one more slide, and it's okay. To this of of what can we actually do about this problem. It's a really difficult situation that we're being put in as a state, and in particular in the Tri-Cities. And so what can be done? And I think the answer is in some sense quite a lot, right? We know certain things worked, and we even saw them work in the past in Tri-Cities. So from mid-March to mid-April, these types of mitigation efforts, staying at home, physical distancing when you're out, face masks, and even eye protection, they contribute to decreases in transmission that the scientific community is starting to see more and more. So this first plot I have is for King County and Yakima County. One of the things that we've been looking into is to what extent can we correlate what we see in transmission. So the y-axis there is these are effective estimates that we have for King County and for Yakima. And then on the x-axis there is data from a cell phone company called SafeGraph that collects anonymized cell phone location data to make estimates of things like to what amount of the time of the day is the average person in this county spending at home. And we see this really clear signal that the more people are staying at home on average, the less transmission we see in the communities in King County and in Yakima County. Adding to that, things like physical distancing, face masks, and eye protection, that can make a big difference in terms of person-to-person transmission of COVID. And so, yeah, we can't stress enough that throughout the data we've seen, even from Tri-Cities, we've seen the effects of these things and that they've been positive. And so making sure that everyone, does their part to try to protect their community from this growing problem. This is what it looks like. It looks like face masks. It looks like standing a meter apart or 6 feet apart, being cautious in that kind of way when you're out. Yeah.
Oh, this is great. I think, like we said before, this is really the point that having you on today, having this deep dive on data, which I think is great. We're getting a lot of positive, feedback from the question and answer on Facebook. People are really appreciating your jump into the data. But that's exactly the point that we wanted to bring out, that there are things that we can do. I think that's since we're one of 2 or 3 counties that are still on phase 1, people are getting frustrated and they want to get back to some sense of normal. But I think at this time, our clear message is it's time to double down. We did it before. You could see in those transmission rates earlier on, to your point, back in April, we were close to or dipped below 1. We need to get back to those things. And this is exactly what people can do, what we can each do to have that responsibility to change our outcomes as a community. And I know, I'm new to the Tri-Cities, but the Tri-Cities has a long history of coming together as a community to overcome big obstacles. And this is a great example of that. We need to pull together, use social distancing, face masks, and, limit our travel as much as possible. And, that's what we can do to affect this outcome.
Yeah, I think that's such a good point that there's so many examples where communities like the Tri-Cities have banded together to really accomplish things. And this is one of those situations where, like you said, doubling down, that's what it's going to take.
That's right. Well, and you said that was your last slide. So if you're ready, we'll get into some more questions. We got about 15 minutes left. So, and you might not be aware of this, but you knew about the Tyson Foods. So we did have an outbreak at the Coyote Ridge Correctional Center, which is up in Connell, which is still in Franklin County. And so there was an outbreak amongst the inmates and amongst the guard and administration. So are you guys aware of that? And maybe this is more of a local health district question, but is it a good opportunity for contract tracing and then, seeing how the disease spreads? I don't know if you guys are aware of that or you're seeing a spike in that data, maybe even related to testing, just like you talked about at the Tyson plant outbreak.
Yeah, that's such a good question. I think it's one of these situations where, we're realizing the ways that COVID sort of connects everybody in society, even people that we day to day don't think that we're connected to. And so, people in the correctional facility and the guards who then go out and interact with other people in the rest of society, what we're finding out is that this disease, where person to person transmission is how it gets around, it's really connecting a bunch of factors in society, a bunch of facets of society. And so contact tracing helps us in the sense that we can see bits and pieces of how it's getting around. And one of the key examples of this that we've been really thinking about a lot is agricultural workers in Yakima, for example, where originally we saw that the outbreak was really concentrated to agricultural workers in Yakima, and then over time it spread into lots of different places in society. And so I think what that speaks to is that, we have each of our societies, like each of our communities, Tri-Cities, Yakima, King, we have different types of vulnerable populations. And COVID-19 connects us to the outcomes associated with those vulnerable populations in a very real way. So understanding the transmission, say, at the Coyote Ridge correctional facility, what that gives us is a window into transmission in particular communities. But what we know from the high level picture is that all of our communities are connected. And so that's sort of how we start to think about these kinds of things.
Oh, that's great. Thank you. We had a question about asymptomatic testing as was done in New York. I don't even know exactly what that means, but I see you nodding your head. So
yeah.
Can you talk a little bit about that? And is there any, even statewide, any chance for asymptomatic testing? And obviously, I think it probably relates to the fact that if you don't know you're sick and that you can spread the disease, is there some way for people who are asymptomatic to know, and then to make sure that they double down on, social distancing and staying at home and stuff?
Yeah, it's such a good question. So to clarify, we know that for a lot of people, COVID-19 doesn't present really serious symptoms, or maybe no symptoms at all. And so these are people who are actively spreading the virus, but completely unknowingly. And there's a couple things to say about that. So in certain places like New York City and like Seoul, South Korea, and even to some extent, places in Washington, there have been tests that have been administered to people who show no symptoms at all. And that helps us get an understanding of to what extent do we think there's prevalence in people who are not typically being caught by the healthcare system. So I think that that's one of the things that, in trying to ramp up or in trying to double down in some sense in a place like Tri-Cities, that's one of the things that as a healthcare community we'll have to make sure we think seriously about. But what will give us insight too is how many people are actually actively infected right now. And that's something that we also get insight to just from looking at the current case data. And it's not going to change our perception that this is not a growing problem. I think we can see clearly from hospitalizations and things like that the problem is growing. And so when it comes to, as a person, not knowing if you have the disease, I think that's what we mean when we say it's time for like preemptive actions, things like wearing a mask, things like being vigilant about washing your hands, things like being vigilant about, if I can stay at home, actually do stay at home. And when I do go out, when I need to go out, maintaining those 6 feet of distance and things like that. Those are the little things that we can do that, for someone who doesn't know if they're infected or not, helps to prevent spread. And I think because testing is lagged from the actual transmission events, even if we had asymptomatic testing, we would still be behind. We'd still be driving from the rearview mirror. And so I think we just have to be proactive. And I think in the places where COVID transmission has really been curbed, it's taken a community-wide effort to be proactive in that kind of way.
Oh, that's great. Well, on those lines, locally, the health district and the National Guard just opened up drive-through testing for that. And it's our understanding that anybody can call 211, make an appointment, and do a drive-through testing. So maybe even on the asymptomatic discussion that you just brought up, I assume we should be encouraging everyone to get tested. Is that
absolutely? Yeah, and right? It's because it gives us the sense of, okay, people who need to stay at home, and very importantly, if you get a positive test and you're asymptomatic, you can warn your close contacts, people that you're around a lot. Hey, like maybe you should be staying at home too, even if you don't feel sick, because we know that these things are happening faster than we can catch them. And so that's the kind of ways that we can try to be proactive and make a real difference.
Oh, that's great. We have a question from Facebook on how far behind does the data lag? They're curious if any of the counties that reopened have had their R factor climbing 2 or exceeding 1. And I think on the call last week, I think you guys had some data about Spokane County, and maybe that's a good example of a county that's gone to phase 2, and they are actually having a bump up in their transmission ratio or just in their overall cases.
That's correct. Yeah. So that's something that we were seeing late last week. And so in our meeting with local leaders on last Saturday, we were talking also about Spokane. And then today we will publish another situation report. So we publish these weekly situation reports where we look at particular parts of the state. And in this week's situation report, we'll have a little bit on cases in Spokane and the trends in Spokane, which are in fact starting to rise. And that is, at least in terms of timing, associated with some of these reopenings and some of these transitions to phase 2. But like I said previously, the model doesn't give us so much causal insight. We can't say, oh, it's because people are going to restaurants. We don't know the answer to those kinds of questions.
Sure.
And it's because things are happening really fast and we're observing them so spottily and at a high level. And so I think at the moment, what we can say is that, based on things like the cell phone data, mobility, like people are moving around more. And then simultaneously, as people are moving around more, we're also seeing increases in transmission. And in terms of timing, they seem associated with one another.
Oh, that's great. Well, I think that's a great point in that even as counties are opening up, that they still need to do the same things that we're asking everybody to really double down on here, those same factors, because there is this huge correlation that even though maybe you have a low case count, you go to phase 2, you still need to social distance, you still really need to wear a mask, you need to do all these things. So I think that's a great reinforcement of those points.
And it's like, part of why you do these things proactively is because by the time you see the problem, it's already too late, right? I was talking about, being from Arizona, and I'm sure if you've seen the news, the situation in Arizona is truly scary. And, for my family and friends that still live there, I'm worried for them. And what when you see a problem as big as Arizona's problem is that the actions that could have stopped that should have happened weeks ago, right? The proactive action could have done something about that. It's in some sense already too late when the problem is staring you in the face. And so when we're talking about things like reopening, I think still maintaining some of this vigilance, these proactive actions, mask wearing, hand washing, physical distancing when you're out, that's how you make sure you get ahead of these things before they become really, really serious issues.
Oh, that's a great point. Well, and I think, you talked about it before, but maybe you could talk a little bit more about, just reminding us, and I think especially this has really been a great discussion. We really appreciate your time here. But just remind us that, we're like 6 months into this disease. It really is novel. It's brand new. And I think you've talked about it a couple times, but you want to talk a little bit more about that, about, how does, IDM being a great example, how do we as a society, how do we as data scientists like yourself, try to figure out and get ahead of this when it is really so new? And because I think that to a certain extent, a lot of people think, well, why don't we have it figured out? Why doesn't, this government agency or this local agency or public official have this figured out and then, fix it for us? But do you want to talk about just how new this is and how rapidly things are changing?
It's such a good question in the sense that so the first case in the US was caught in Snohomish County on January 15th, roughly, right, of this year. And so, this is in its infancy, this virus in some sense. And we're learning quickly every day about how it moves through society. But anyone who's been paying attention to the news has realized that there's a lot of uncertainty about how does this actually get around? What are the ways that people are getting infected? Is it on surfaces or is it in the air? These kinds of things, right? But one of the things that we can say with some certainty today that we couldn't have said before is that some of these social distancing measures, things like masks and things like that, they've had a real impact. Like we've seen the impact. So something we've learned over the last 6 months is that these non-pharmaceutical interventions, they've really changed the course of this epidemic, even locally, right? Even in Tri-Cities. And so, I think overall, zooming out for a second, the collective efforts of lots of people, the elected officials we have, the public health officials we have, the scientific community we have, and doctors and nurses and healthcare workers, all of them contribute to a growing understanding of all things COVID. Not only how is it getting around in society, which is something that I can speak to, but also how does it get around in your body, and how does it get around from person to person? How do these things like hand washing really make a difference? And what are the different types of what's novel about this virus that makes it so dangerous and so lethal? Those are things that the understanding has grown really, really fast and continues to grow as scientists around the world and healthcare officials work towards getting better and better solutions. And so in some sense, physical distancing is what we have right now. But I'm hopeful that as we learn more and more about how COVID is transmitted from person to person, that we'll start to get more and more creative strategies and maybe even pharmaceutical strategies for dealing with things. But that's something that we have to just, I think, as we learn more, work towards as a society.
That's a great point. It just reminded me of, really how much, especially public health, was established in our country 100 years ago, right? Like with the great influenza outbreak of 1918, 1919. And I think it's interesting, kind of the historical correlation is that the things that our nation did to stop that outbreak 100 years ago are the same things we can do today. I mean, you look and you see these 100-year-old pictures of people wearing masks, people social distancing. I mean, I saw some pictures from, I think, San Francisco where they were holding a court trial outside. I think that's the interesting thing to your point, is that because it is so new, we can always go back to the basics. I mean, to use a football analogy, I know you like soccer from your bio, but football analogy, right? We can go back to the blocking and tackling. We got to start with the basics. If we do the basics, we can have an effect on the outcomes. And I think your data is great, because what you showed us is that right here in Benton and Franklin County, we were doing the right things. We were staying at home. We probably weren't wearing masks. It was probably more related to staying at home, and we were social distancing and washing our hands. And we actually dipped below our transmission ratio of 1, which is the goal. We need to get back there. We need to be able to do it again. And I think describing it as doubling down, now's the time we can do it. And I really liked your analogy on the weather, but can you give us that analogy one more time, and then we'll close up for today?
Yeah, absolutely. Yeah. So one of the key differences, I think, between the weather and this and COVID is, the weather is one of these things which are very complicated, and it's happening around us, similar to COVID. And it's something that we try to use models to understand better and to make predictions about the future. But when you decide to act on what you've observed in these models and what people are telling you, the weatherman tells you, you don't have an effect on the weather. So if you wear a raincoat, you don't change the weather. If you decide to wear an umbrella, you don't change the weather. And if you wear shorts, you don't change the weather, right? That's not the same as COVID. And that separates COVID from like a natural disaster or something. It's not just happening to us, it's something that we have control over. And I think things like mask wearing and the way that that's different than having an umbrella is that it's a way to go outside and take control of transmission, but also signal to your community that you recognize that your actions have implications for everybody around you. And in that way, I think it's just a very different thing. We get to choose what the future looks like in this kind of way. And it's not something happening to us like the weather.
That's perfect. And a great way to sum it up. Niket, I want to thank you again for joining us today. This has been great data, and we appreciate you on very little notice, jumping in and being able to share this data with us and some great takeaways. Really appreciate your time. And I think you did say you're going to be able to send a PDF of your slides, and so we'll be posting that on Facebook and on our TRIDEC.org website that we talked about before. So thank you very much for joining us today.
Yeah, thank you for having me, and thank you guys for doing this. I think these types of community conversations specific to your local setting and to where you are and to where your neighbors are at, that's how we start to make a difference here. And so in that sense, I think it's great stuff, and I'm glad to be here.
Oh, thanks. Well, again, thanks everybody for joining us on Coffee with Karl. This has been a great discussion with Niket Thakkar from the Institute for Disease Modeling. We talked about data today. I just want to make one last point, and that is yesterday I was able to watch the Badger Club's presentation with General Mattis. Great Tri-Citian and a great leader in our country. He made some great points. He talked a lot about the Tri-Cities, our history, and even the greatest generation, and that won World War II. And I think that, this is that kind of an effort. We need to come together as a community. In World War II, we joined as a community to defeat fascism and win World War II, and really had a huge influence. And we did that through personal sacrifice. That's really our message here today. We have that chance to do it again. We need to double down on wearing masks and social distancing and make sure we adhere to the guidelines. They're hard and they're frustrated, but it's the things that we have to do because we can control our own future and our own destiny and get to that phase too. So again, thank you again. Thanks everybody for joining us today. And we'll see you again next Friday for Coffee with Karl. Thanks.
Thank you.